like to ask the audience to have good questions. Yeah, so please, speakers, come. You can ask each other questions also. Okay, there's already somebody. The microphone.
I think we didn't ask any question. Oh, sorry.
Volker Simpson from Leipzig, Germany. So maybe some colleague of the prolific group of Madrid can answer the question. If you look to Staphylomata, you showed nice and interesting cross-sectional data. I would be interested, what is your idea in the lifetime? When does the extent and form of Staphyloma evolve? Can you say at a certain age that you won't expect a Staphyloma, and would you comment, you shortly touched on the asymmetry in anisometropia, but is there a certain likelihood, an increase if you have a difference in axial length between two eyes?
Great question, but difficult one. You know, like posterior staphyloma, it is very difficult to put like an exact moment that it is starting to grow or to develop. There are small kids that have posterior staphyloma at 5 years old, and others that develop around the 40s or 50s. I think that we don't have, any one of us, we have this answer. What we have studied that is comparing like with the same axial length is the difference with if they have or not or didn't have a posterior staphyloma, and most of them, mostly they have, both eyes have posterior staphyloma. So I think it has to be a lot of matter with genetics. Probably Professor can explain more than me, but I think it's the main reason.
Thank you.
Yeah, if I answer about the genetics, so we have looked at it, but it's found it very difficult to find genetic factors that go beyond the determination of axial length and age as the onset of staphyloma.
Yes,
So the person with the bilaterality, could you also comment on that the bilaterality is very much related to axial length and age?
And when we studied the bilaterality, the unilateral group have a greater AL, and when we study the asymmetry, it's very interesting because in patients with asymmetry, the axial length is the same. It's not, there are no statistical difference between groups.
That is interesting. Yeah.
It's very interesting, yes.
Can you tell me a little bit about the statistical method you used to get your results? Was it multivariate one?
Can you repeat, please?
Was a multivariate analysis for the results, all the results about staphyloma and visual results, outcomes?
But we use different methods. It depends on the study. Okay. If you can specify, because there are a lot of studies, a lot of different particularities, bilaterality, asymmetry, so we use different methods. It's a very little more complex, yes.
Thank you.
I also have a question for that.
Yeah.
So which kind, it's not so easy to find the staphylomas. So which kind of OCT did you use? Because basically the diagnosis and the position of the staphyloma is based more than the by microscopy is made on the OCT finding. So which kind of OCT did you use? Thanks.
We perform OCT to all of our patients. We have used Triton, and we use also Canon for some cases. But anyway, we think that to define perfectly posterior staphyloma with ophthalmology, and there is ophthalmology. But we use both of them with a 12 scan. But we use the Canon with 25, and it wasn't so easy. We prefer the ophthalmoscopy, wide field Canon, but it wasn't. But anyway, we prefer we prefer with ophthalmoscopy. But if you have tried with Canon, it wasn't so useful with microscope. But it was useless for us. Yes, it is. Yes, it is.
Okay,
Yeah.
let's go
There
on
is
to
a
the next
question.
question at the microphone.
Maya Saleh from Ivory Coast. Did you study the relationship between choroid and the staphyloma in these patients?
We studied a lot a long time ago about choroidal thickness, but not with posterior staphyloma. But most of them has a really, really thin choroid, so we don't think it was a big difference.
I have a question for the subject on atrophy. You found that hypothyroidism can influence the atrophic changes. And do you have any clue why? What would be the physiopathogenesis for that?
We did not study.
Can you-
That was
Can you lower the mic?
sorry. We did not study the reason why it might be a risk factor for larger atrophic areas, but some studies about that topic mention a doubt about what would be the mechanism, rather hypothyroidism, the disease, or the hormones replacement that patients do when they have hypothyroidism, and the potential effect of those hormone replacement therapy on the RPE response to the damage triggers, and so later on the atrophic areas evolution.
So if I understood correctly, it's the treatment
The
for
treatment, yes.
hypothyroidism
Some
that would
studies-
be the
Yes.
cause. Okay, thank you very much.
Yeah, and I have a question for Dr. Ferretti, because it's amazing that the results of the review. So did you find any difference by the literature in ethnicity?
Excuse me?
Is there any difference in how the anti-VEGF, the long-term results in ethnicity?
Unfortunately, that kind of study is made by aggregate data, not on a single patient level. So, and another important limitation is that the randomized clinical trials also include many patients for Asian countries, but real-world experience are most on European, Caucasian patients. So, in our study, we took that in consideration, but did not find any significant influence on the long-term outcomes. However, I cannot assure this as a result that is for sure, because given the nature of the data we elaborated.
I understand. So is there another personal view that there is an ethnic preponderance for outcome?
Excuse me?
So now I'm asking if you or
evidence.
anybody else has the idea that in Europe we have different end results than it would for Asians, and that's why we should maybe be careful in over-interpreting Asian results?
I have to give a talk on Saturday precisely on the differences between the East and the West. And I think we're not that different. Prevalence is different, that's true. But maybe there's a slight difference on the prevalence of the different types of staphyloma, which may explain why they are so severely endangered, or the vision is endangered by high myopia. They have a higher prevalence of macular-centered staphylomas. And on our sample, we almost reached 1,000 eyes. The prevalence of peripapillary or inferior staphylomas is higher relatively when compared to them.
I have a question about that, about the type of staphyloma. You used the Curtin classification, and did you notice any change? Because Curtin is like 40 years ago now.
Mm-hmm.
So did you see any change in the proportion of patients with the different types of staphyloma?
As Dr. Fuller said in his talk, we've used both. We use Curtins and onomatsuis, and the relative differences between them are not very significant. And the most prevalent types of staphylomas are still 1 to 4, maybe. So
No,
there's really not that
I
different.
wanted to know if you compared your results with the results of Curtin 40 years ago, and if you noticed any difference.
There's a difference, but it's true. His sample and ours, I'm not sure it's
Yeah,
100%
I know,
comparable, but it's true that he describes a much higher presence of maybe type 1 staphyloma, and our variability is higher.
Okay.
But I think I'll keep that for Saturday.
Okay, thank you. Interesting.
Okay, yeah, go ahead.
I would like to answer the question of Caroline. In my own experience, but I ask also your opinion. I'm facing myopic CNV, the CNV since 10 years minimum, and the idea I have is that Italians, Caucasian, the mean age of onset of the lesion is bigger. For example, in my database, the mean age is 65. When you see the studies coming from the East, it's 10 years before. This is but it's just an impression. I would like to ask your idea. Thanks.
I agree with you. Our patients are older than Eastern patients with myopic CMV. Sure. Probably the difference is the genetic. The finish of our studies is we have studied samples of all of our patients to try to identify genetic factors. Sure is definitive in this pathology. Thanks.
I feel the pressure. So, but you don't think that Asians, even in the high myopes, have a little bit longer eyes than Europeans do? And that could also be the result?
I don't think so. We have compared, it is not so different. What I have seen also is that CMV patients from Asia probably have shorter axial length than ours. So, and we have more macroatrophy due to patchy atrophy enlargement and CMV than theirs. So probably it is a difference with the CMV.
Thank you.
Maybe to conclude, I have 2 questions for you for the surgical subject. Do you think that the fact that you saw a difference between patient that you injected ICG
Yes.
Could be a bias in the sense that maybe when you didn't have to inject ICG, it was easier to peel?
Oh, with 3D? You mean with 3D or without 3D?
Well, without the groups, I mean, the fact that
Yeah, but
how,
okay.
Who judges that it's not necessary to inject ICG?
Yes, the study was conducted by a single surgeon. It's my mentor, Dr. He, and he's kind of expert in doing the tractional myopic surgery in high myopia patients. Yeah, so we usually inject ICG instead of BBG for high myopic patients because the LM was really difficult to detect with BBG. Yeah. It's really like no use or something like that. But with non-highly myopic eyes, we do BBG for like the ERM peeling or macular hole surgery for non-highly myopic eyes. Yeah, so the choice of ICG for high myopia patient is due to the difficult detection of the IRM.
Yeah, I know why ICG. I just wanted to know why in some case you don't use it and in another case you use it.
We use it every case, so there are some cases just need one injection.
Ah, okay. I didn't understand
all
that.
with
Okay.
ICG.
Okay. Thank you very much.
Okay, with that, I would like to close this session and thank the speakers very much for great talks on a great topic. And I wish you all a very good Euretina.